Hi, good afternoon, everyone, and welcome to our CME, Department CME today, this afternoon. So today we're going to have a topic on critical care, from the critical care discipline. Today's topic will be acid-base balance in critical care. Today's presenters will be Dr. Stephen Wong and Dr. Jian Meng, and also myself, a small part, and this will be supervised by Dr. Feng, our intensivist. Now, while we wait for the others to join in a bit, just a few quick announcements. Number one would be membership for medical society is still open to those who haven't joined. You are still welcome to sign up. All right, and then secondly, for new MOs who have joined the department but have not introduced yourselves yet, after the session, if there's time, you may just unmute yourselves, show your video, and also introduce yourself to the rest of us here in the department. Okay, so I think we'll just wait another minute and then we will start our CME today.
Hello, very good afternoon to everyone. My name is Dr. Stephen, and we will be presenting about acid-base balance in critical care. Our contents of this presentation will include basic principles and definitions, some basic anion gaps, delta gap, some stepwise approach to blood gas interpretation, oxygenation part, and some clinical case scenarios. We will end it with to discuss about some the role of bicarbonate in patients with severe metabolic acidosis as well. So some basic principles and definitions. So acid donates hydrogen ions, a base receives the hydrogen ions, and according to the Henderson-Hasselbalch equation, the pH is equal to 6.1 plus log and bicarb divided by 0.03 times PCO2. So usually, right, to achieve equilibrium, the bicarb and the PCO2 will alter in the same direction in both a primary and secondary response. And as for the definition for standardized base excess is the amount of acid or base that restored 1 liter of blood to give maturity at a PCO2 of 40 mmHg. And for the actual base excess is actually derived from the formula based on the Henderson-Hasselbalch equation. So the main players of maturity which will affect our pH. Actually, it depends on which factors actually. So they include the buffers, which includes the bicarb, proteins, and phosphate in our body. And as for the respiratory component, our pulmonary alveolar ventilation can actually affect the PCO2 tension depending on the patient's ventilation. And our kidneys can also affect the hydrogen ions increase by hydrogen secretion with titrable acids, as well as proximal bicarb reabsorption, thus affecting our pH values. So just a brief reminder or brief revision. Our pH is 7.35 to 7.45. PCO2 is 35 to 45. PO2 is actually depends on the patients and FiO2. Bicarb is 22 to 26, and base excess is -2 to +2. So we'll move on to the anion gap. So basically, we use anion gap when patient has actually metabolic acidosis to determine whether it's high anion gap or a normal anion gap metabolic acidosis. This actually can help us to guide our investigation and medication. So there are actually two formulas for anion gap. So number one is actually the US one, just sodium minus chloride and bicarb. Range is 10 to 14. However, for the UK one, we include the potassium. So the range would be 14 to 18. It's just a class of 4 actually. And so for high anion gap metabolic acidosis, I would be using the mnemonic MUD-PALS. MUD-PALS is actually stands for methanol, uremia, DKA. Yeah, that's good. You want to put here? Yeah, put the mouse here. This part. Yep. Methanol, uremia, DKA, paraldehyde, iron, lactic acidosis, ethanol, or ethyl glycol, as well as salicylic acid. So all of this can actually cause a high anion gap metabolic acidosis. And for the normal anion gap metabolic acidosis, the mnemonic for me is actually just use carb basically. So uteroenterostomy, fistula, extra chloride, diarrhea, carbonic anhydrase inhibitor like acetazolamide, Addison's disease, renal tubular acidosis, as well as pancreatic fistula. So based on this, we can actually kind of like know what is happening to our patient based on ABG alone. And next, we'll be talking about the delta gap. Okay, what is delta gap? Delta gap is actually used to identify whether the patient has mixed metabolic acidosis or some complex base disorders. So the formula is actually just the difference of anion gap to the normal values divided by the difference of actually bicarb to normal values. So the principle of this delta gap is actually when the anion gap increases in magnitude as a result of metabolic acidosis, this increase should be actually compared with the magnitude of fall in bicarb. So based on this formula, actually, if the ratio of the delta gap is actually 1 to 2, it's actually uncomplicated HACMA. However, when it's actually less than 0.4, means it's actually a pure normal anion gap metabolic acidosis. Why? Because if the value is actually less than 0.4, which means actually the anion gap is low. So when the above is low, right? So it will create a very low value. So negative 0. I mean less than 0.4. So if it's 0.4, 0.8, it's actually NACMA and HACMA mix. And however, if it's more than 2, it's actually high anion gap metabolic acidosis plus a concomitant of increase in bicarb, which can be caused by metabolic acidosis, alkalosis, or chronic respiratory acidosis. So, so this is a very good example of the delta ratio. So, and next we move on to the osmolar gap. This is just to actually identify any abnormal solute present in the blood actually. So we should calculate our serum osmol by 2 times sodium plus glucose plus urea. Normal is 275 to 295. And the osmolar gap is actually our measured, you can actually measure in the lab actually. So the measured serum osmol minus the calculated osmol, normal is actually less than 10. However, when it's raised, right, it could be caused by a number of conditions, which include like ethyl glycol injection, methanol injection, severe CKD without regular dialysis, ketoacidosis, lactic acidosis, paraldehyde injection, or those who without any anion gap metabolic acidosis, which includes ethanol, diethyl ether, infusion of mannitol, or pseudohyponatremia. Next, I'll pass the mic to Ho, and we talk about the stepwise approach.
Hi, I'm Ho. I'm going to talk about a stepwise approach to blood gas interpretation, as well as a small talk on the oxygenation part. So when we look at the ABG, first we should know a bit about the clinical history of the patients, then we look at the ABG as well as the RP. So when we look at the ABG, first we look at the pH, decide is acidosis or alkalosis, then only look at the primary event, decide metabolic or respiratory, and then check on the compensations. So this was the same. So let's talk a bit about ABG, some of the common error during ABG samplings. So any delay in analysis can cause any alter in the value of the ABGs. Causes consumption of the oxygen and the production of CO2 after the blood was withdrawn. So if ice sample, the value can maintain for 1 to 2 hours. In unice samples, it will quickly become invalid within 10 to 20 minutes. So another one is the effect of fever or hypothermia. So most of the ABG analysis report at the normal body temperature. If severe hypo or hypothermia, the value of pH or PCO2 can be different, depending on the temperature as well. So excessive heparin also can affect the ABG interpretation due to the dilutional effect and cause a low bicarb or low PCO2. Then air bubble also can affect the ABG reading as well, because the PO2 at around 150 millimeter mercury, and then the PCO2 is 0 in the air bubbles. When mixing with the sample can cause an increase in PO2 or drop in the PCO2. So to avoid air bubble, the sampling should draw very slowly and preferably in a glass syringe. And then the steady state, usually sample should be done after the steady stage in the change of the oxygen therapy or the ventilator setting as well. And steady state usually achieved within 3 to 10 minutes. So and the approach to read the ABG, first look at the pH to decide the acidosis or alkalosis. So in acidosis, the pH is less than 7.35. Alkalosis, pH is more than 7.45. And then we look at the primary component to decide whether it's a respiratory or metabolic. Basically, you can look at the PCO2 itself. So if it's acidosis with a high PCO2, it's a respiratory acidosis, whether metabolic acidosis when the pH is low acidosis range. And then we look the PCO2 is low or the bicarb will be low as well. Then we look at the compensation part. So in metabolic acidosis, there will be to compensate, there will be a drop in the PCO2, and then to compensate for respiratory acidosis, they will cause a raise in the bicarb to compensate for the other abnormality present there. So to note whether it's compensation adequate or not, for metabolic wise, we can use the Winter formula to calculate the expected PCO2. The formula will be 1.5 times the bicarb and plus with 8. And then the value usually plus minus 2. Whether it's a metabolic alkalosis, we can use the value of 0.7 times the bicarb, and then plus with 21 plus minus of the 2. Then for respiratory component wise, this was from the Hasselbalch formula. We can convert to pH, or in a simple formula, we can use this one as well. Respiratory part, we can use the 24 convert to the bicarb is the 24 with the PCO2 minus 40 divided by 10. And then for acute and chronic wise, we have a different formula as well. To remember easily, you can use the simple formula like 1 for respiratory alkalosis, 2 for acute respiratory alkalosis, then 3 for chronic respiratory acidosis, then 4 for chronic respiratory alkalosis. Whereas for metabolic compensation wise, we can use this formula. Otherwise, we can alternate is the Winter formula as shown previously. This was a summary of the metabolic compensation for respiratory acid-base disorder. In the acute respiratory acidosis is 1, then the respiratory alkalosis in the acute setting is 2. In the chronic respiratory acidosis is 3 or 3.5 to be exact. Then the respiratory alkalosis compensation is 4. So for the oxygen assessment part, to brief, we look at only alveolar ventilation, PaO2, which is 7.13 times the FiO2 minus 1.25 times the PaCO2. Then the AA gradients is can be calculated using the H divided by 4 and then plus 4. And then the AA ratio is actually basically the percentage of alveolar oxygen entering the arterial system, and the PF ratio is the PaO2 divided by the FiO2. So for alveolar ventilation wise, is FiO2 times with the barrel pressure, which usually 7. This will add usually 7.6, then minus 760 minus 47, then becomes 713 times with the FiO2. And this is minus 1.2 is actually 1 divided by the respiratory portion, and then times with the PaCO2. Then we can decide on the PaO2 of the patients. And then from the then we talk about a bit of respiratory failure. There are 2 types of respiratory failure, type 1 and type 2. Type 1 respiratory failure usually present of hypoxia, and type 2 respiratory failure is the presence of hypoxia together with hypercapnia. So when the presence of hypoxia actually usually indicate a gaseous exchange failure, whereas in type 2 respiratory failure is actually indicate ventilatory failure. So a little bit about AA gradient. The normal AA gradient is usually between 5 to 25, or we can use a formula depending on the age of the patient. It's the H divided by 4 plus 4. So AA gradient is a comparison of the partial pressure of the oxygen in the alveoli and compared to in the arterial blood. So the PaO2 is calculated based on the formula I mentioned just now, whereas PaO2 can be measured from the ABG. So AA gradient increase indicate that the partial pressure of oxygen in alveoli is much higher than the partial pressure of oxygen in the arterial blood. Indicate a VQ mismatch, can be due to dead space ventilations, left to right shunt, or alveolar hypoventilation. So a bit on the ARDS and also PF ratio. So this is a varying criteria for ARDS severity. So according to the definition, the timing usually in 1 week of a non-clinical insult, whether it's new or worsening of the respiratory symptoms. And then the chest X-ray changes of bilateral opacity not fully explained by effusions or lung collapse or lobar or any nodules. And the origin of edema usually not because of the cardiac origins. And then we depend on the PF ratio, we can classify into a mild, moderate, or severe ARDS. The PF ratio will be 200 to 300 for mild and 100 to 200 for moderate, and then less than 100 for severe ARDS. And then it's also associated with increasing mortality when the PF ratio is lower. So we talk about a first case scenario here. Our first case scenario is a 56-year-old female with underlying hypertension, pneumatoid arthritis, and psoriasis. So this case was presented with a SOB for 1 day and then fever and cough for 5 days. So it was a lethargy and speaking in sentences when present to our ED. Then subsequently, noted the SpO2 is only 86% under room air. Subsequently, put on face mask, then a high flow mask, and then was put on high flow nasal cannula and admitted to ICU. And subsequently, due to increasing oxygen requirement and respiratory distress, subsequently was intubated. So can see from here, this is the initial presentation on high flow nasal cannula. This is the ABG so the pH wise is actually on a bit of the alkalosis size. Then we now look at the PCO2, which is low, that indicate that this is a case of respiratory alkalosis. Then we subsequently calculate the compensation wise. It actually shows compensated acute respiratory alkalosis. And so for the oxygenation wise, we can calculate the PaO2, which is using this formula, and this is the value we get. So subsequently, we can calculate from the AA gradient from here, which this one minus from the ABG value is very high AA gradient, and the normal AA gradient for her age will be 18, and then this the PF ratio is 160. Subsequently, so was dropping of the PF ratio as well. So from here, we can see actually respiratory alkalosis over here. Then on the day 9 of the ABG, from here you can see a bit of the alkalosis, and then the bicarb is high, and then the PCO2 normal, so it's actually metabolic alkalosis. And for the compensation, what you can calculate using the PCO2 is actually showing compensated metabolic alkalosis. And then subsequently, post-intubation is can see from here the pH is on the lower side, and then the PCO2 is a bit high, so it's a respiratory acidosis in the ABG post-intubations. And then we look at the bicarb, and after calculating the compensation using the bicarb, it's actually showing a component of metabolic alkalosis as well, possibly due to the steroid usage. So this is the X-ray of the patient.
Hi, sorry guys, Wong here. Can you rewind one slide? Sorry, I just want to point out something. So this lady, of course, the initial one, the first one, you're right. She initially had respiratory alkalosis, right? The pH is high, so there's alkalosis there. The bicarb is on the lower side, yeah, but the CO2 is low, so it's a respiratory alkalosis. And there is some metabolic component, metabolic compensation.
Yeah.
Then subsequently, I think what happens in this patient, I'm not sure whether it was dehydration, or whether it was given bicarb. I can't remember, but subsequently, I think the on day 9, the one with the pH 7.49, this one it's actually both are alkalotic, If you look at the CO2, it's also below 40, and the bicarb is high, above 24. So actually, it's a mix. It somehow became a mix, respiratory and metabolic alkalosis. So actually, in this case, you wouldn't have to, calculate the compensation. I think it's already both a mix. It's considered as mixed alkalosis. Kan?
Yeah.
Right? It should be mixed.
Yeah, but the compensation based on the calculation is still in the compensation range, just except for the day 6 to day 7 time. It's actually a mixed component of the respiratory alkalosis and a bit of metabolic alkalosis, slightly.
Okay. Yeah, but it's actually mixed already. Yeah. I wouldn't say there's a CO2 compensation, because if there is compensation, then the CO2 should be high. It should be higher, right?
Yeah, but using formula actually showing compensations based on this.
But you shouldn't say it. You shouldn't. We shouldn't say that there's compensation, because it didn't compensate.
Yeah, because
if there was compensation, then the CO2 will go higher and higher.
Yeah,
and then the pH will come down, but this one didn't. Yeah, so we wouldn't say it. Just say there's a mix. Just say it's a mix alkalosis.
Alkalosis, yeah, the respiratory alkalosis.
Just mix only. Yeah, just mix only.
Okay,
yeah. Proceed. Thanks.
Is the X-ray of the patient. Subsequently, we proceed with a CTPA as well, showing a severe OP, and then the evidence of PE in the CT scan as well. The outcome of these patients subsequently was done tracheostomy and then decannulated after some days and subsequently saturating under room air since 8th of January and discharged home on the 15th. So come to a second case. It's a case report from a Canada Emergency Journal. It's a 38-year-old gentleman which appeared drunk and then subsequently increasing agitation and also incoherence. Then attended by the paramedic show a normal vital sign initially and oxygen saturations. So after transport to the hospital, patient complained of a worsening of the abdominal pain. At that time, the vital is a blood pressure is 110/70, heart rate is 72, with a normal temperature 36, and then respiratory rate of 22, and then oxygen saturation was still well under room at that time. Subsequently, after 30 minutes, the GCS has fallen to 9 and respiratory rate has increased to 30, but there's no focal neurological sign or otherwise physical examination was still unremarkable. Subsequently, another 15 minutes later, began to having convulsing, and then also a rapid sequence intubation was performed. Then subsequently, patient developed PEA followed by 2 episodes of hypotensive bradycardia. So resuscitation was done using epinephrine, and then started given dopamine and then also transcutaneous pacing while prepare for a transvenous pacemaker as well. So this was the lab result that time. So sodium is 153, potassium 5.4, chloride is 108, and the urea is 5.9, creatinine is 174, and the glucose is 6. This is the ABG that time is showing acidosis, and the bicarb is only 5, and the PCO2 is also 62, and the serum osmol was 487. So here we can see it's acidosis, and it's a mix of the metabolic as well as acidosis respiratory. So because it's a bicarb is very low, so we consider as a metabolic acidosis first, and for the compensation, we can calculate from the PCO2, and it's actually showing a mix of metabolic and respiratory acidosis. Then we can calculate the anion gap from here, which actually showing a high anion gap metabolic acidosis. So, and then we subsequently proceed with the calculation of the delta gap is showing a 1.47. So it's actually a pure high anion gap metabolic acidosis. Then we can calculate the serum osmol from the reading from here, actually showing 317, and the osmol gap is very high, 169. So it's showing that some solute is present in the body. So this is the case of a severe anion gap metabolic acidosis and widening of the osmolar gap. It suggests a toxic alcohol ingestion. Therefore, in Canada, at that time, they started ethanol infusions together with an 8 ampule of sodium bicarb. And the serum methanol subsequently will show out will be positive. So it's a case of a methanol poisoning in this case. So come to a worst case scenario. Mrs. L is an 86-year-old female with underlying hypertension, DM, and also XTB, completed treatment, and then also have a CKD. So this case was referred to Euro Clinic initially for hydronephrosis and a valvular mass at the suprapubic area. Subsequently, did ultrasound and went for Euro Clinic TCA. However, noted the potassium is only 2 during the TCA. Otherwise, patient was asymptomatic and the vital sign was normal, and the ECG is showing sinus rhythm and no U wave was seen. So it was the investigations that subsequently patient was sent to ED. The urea is 5, creatinine is 125, sodium is 140, potassium is only 2, chloride is 117, and the VBG is showing a metabolic acidosis, that pH is 7.17, bicarb is 15, and PCO2 is 43, and the UFM is showing protein 1+ and blood 3+. So it's a case of metabolic acidosis over here. Compensation-wise, didn't calculate because it's not an ABG, and PCO2 in VBG will be higher than the ABG usually. Then we proceed with calculation of the anion gap. In this case, it's 11.3, show a normal anion gap metabolic acidosis. Delta, we can proceed with the calculation of delta gap showing 0.08, which is less than 0.4. This means it's a case of the pure non-normal anion gap metabolic acidosis. So this case is a possible hypokalemia with a normal anion gap metabolic acidosis, secondary possible RTA. And from the ultrasound, this is the chest X-ray and the X-ray abdomen of the patient. And we proceed to look at the ultrasound report of the patient. It's actually showing a bilateral medullary nephrocalcinosis. So that means it's a very high possibility the patient is having an RTA in this case. Now I pass to Stephen to continue with the 2 more clinical scenario, and then also the role of sodium bicarb in a critical care setting.
So hi, so for the fourth case scenario, we'll be talking about a 22-year-old female. He presented, actually it's no medical illness, presented with actually postprandial vomiting of 2 weeks with food contents, abdominal pain for 1 week at the epigastric region, hoarseness of voice for 1 week, autopnea and PND for 1 week. And also in view of impending respiratory collapse, despite giving an IV, we subsequently intubated intubated her. And so based on the blood investigation, the first one is the blood investigation when she presented, and the second one we noted that it's actually worsened with a pH of 6.86, PCO2 of 15, PO2 of 186, bicarb of less than 3. So it's a severe metabolic acidosis, you would say. Then subsequently for the next few readings, it shows that actually it has improved. In view, we actually given a lot of sodium bicarb, we given a lot of fluid resusc, as well as done some HG for the patient as well. So in that point of time, we will be taking the 6.x6 reading. So in that point of time, the sodium will be 127, potassium is 4.3, urea 21.3, creatine is 140 with some AKI component, chloride is 92. And we also noted the lactate to be 18. And from all this we can calculate the metabolic acidosis, whether it's actually acute or there any concomitant. So as for rule of compensation, for the bicarb of 3, the expected PCO2 would be around 13 plus minus 2 based on the actually Winter's formula. So the PCO2 is actually 15, so it's actually no concomitant respiratory acidosis or alkalosis present here. And secondly, we will calculate the anion gap. So from the readings we get just now, it's actually 36.3. So we take, for this one, we'll be taking a UK formula. So it's the range should be 14 to 18. So it's actually highly elevated. So it's actually a HACMA. So for us, the HACMA, the causes will be mud piles. And in this case, it would likely to be caused by lactic acidosis because the lactate was 18. Subsequently, we can calculate the delta gap. Delta gap is actually 1.16, so it indicates a high anion gap metabolic acidosis, a pure HACMA for this patient. And as for the osmolar gap, we didn't manage to get a serum osmo, so we omit that for now. So the conclusion from just a few ABGs and some basic RP, we can actually have an idea that the patient might be having a high anion gap metabolic acidosis, probably secondary to lactic acidosis. So furthermore, these are just a blood investigation. You can see, but post-HT, she actually became better, the AKI improved. Initially, she also presented with actually severe liver failure, actually with elevated liver enzymes as well as elevated total bilirubin. And subsequently, in the ED and in AIM, actually given sodium bicarb, actually 4.2% for 100 cc, 8.4% for 50 cc, and some serofundin, some Hartmann, and also given some NSA regime for actually because patient actually has acute hepatic failure. And we also did HD covered with antibiotics, and from then we can see that the lactate is actually slowly going down. And fibrinogen is normal, so it's no DIC. PCM level is okay, acetaminophen level is okay, so it's not PCM toxicity, and blood sense NOG. So subsequently, we're wondering what's happening to the patient, and we did a CT abdomen pelvis. So it actually shows some narrowing of the celiac axis and SMA, causing ischemic hepatitis and ischemic enterocolitis. So differential will include retroperitoneal fibrosis, lymphoma, and periarteritis. So our diagnosis for this patient would be it's actually a narrowing of celiac axis and SMA throughout course. It could be due to autoimmune, could be due to retroperitoneal fibrosis. You have to work out for that. But for this case, we will just want to focus on actually the acidosis part. Okay, so she actually has severe lactic acidosis, AKI, and transaminitis, likely secondary to the ischemic hepatitis and ischemic enterocolitis caused by the narrowing of the celiac axis and SMA. So subsequently, this patient, we managed to extubate her, and giving the hydrocort, maybe actually for the retroperitoneal fibrosis, it kind of improved a lot, and she managed to transfer out to a normal general medical ward. So just an example of a metabolic acidosis secondary to lactic acidosis. Yeah. So as for the last scenario, move on to the last scenario. It's a 41-year-old lady, no medical illness, presented with vomiting for 2 days, more than 10 episodes per day. Food content had some bloodstream vomiters as well, associated with some abdominal pain, shortness of breath, mainly at the epigastric area. No bowel output for 6 days, not passing flatus at all. Loss of weight for 10 kg in 2 years, and on and off take jamu, no NSAID consumption, and it's actually an active alcohol consumer. 1 bottle of hard whiskey liquor per day. So when we assessed her in ED, noted she actually has a full GCS by technique, BP a bit on the high side, blood pressure on the high side, and DXT initially was actually 7. And see, based on the ABG, we can actually note that the pH is actually 7.07, bicarb is less than 3, lactate is cool, which is borderline on the high side, I would say. PCO2 is actually 10. So we can say that this patient could be having a GOO with metabolic acidosis and as well as hyperlactatemia for this patient. So from this reading, we can actually interpret it, can actually have some clue of what's happening to this patient. So it's actually a metabolic acidosis, and we want to calculate the compensation whether it's acute or chronic, but actually there's no ABG available. However, no ABG available. It's better to have an ABG rather than a VBG for this patient because the VBG reading will be, the PCO2 will be higher. And subsequently, you can calculate the anion gap, which is 24, which is raised more than 10. So it's actually high anion gap metabolic acidosis. And for the delta gap, it's actually 1.1. So it's actually a pure anion gap metabolic acidosis. It's between 1 to 2. So we will be thinking, because the lactate is 2, so this could be a HACMA secondary to maybe lactic acidosis, but usually the lactate of 2 wouldn't really cause such a severe and high anion gap. So other than that, we actually put her on nesoprom. New by mouth, we give serofundin of 60 cc 3 pints per day, and we actually resusc her with actually sodium bicarb as well. So after the post bolus, ABG slightly improved, actually bicarb become 6.5, but the lactate actually worsened, become 2 to become 3.4. And subsequently noted IVC 0.7, so it means that we can give more fluid. So we give another 3 pints of cereal and given a second sodium bicarb for this patient. And we also taken ketone, and we also run another sodium bicarb as well afterwards. Seems like there's not much improvement. Then after that, we actually given 3 pints of normal state NSD5. Then noted the DXE was 24. Then that picked us to actually take a serum ketone for the patient, and serum ketone turns out to be 4.8. However, she actually improved after all these boluses and sodium bicarb. Bicarb becomes 7.8 already. And subsequently, we treated her as actually DKA regime. And subsequently, her ABG actually kind of improved a bit, and serum ketone reduced already. So we will be thinking this because she is actually taking a bottle of hard whiskey liquor every day. So this could be actually just due to alcoholic ketoacidosis causing a severe metabolic acidosis. Yeah. So this is just an example. And now we move on to actually the role of sodium bicarb in patient with metabolic acidosis.
Okay, hi, good afternoon, everyone. Josiah here. So I hope what Stephen and Ho presented would give us all a refresher on approach to acid-base balance and how to interpret blood gases, especially in the context of metabolic acidosis. Now I'll be talking a bit about bicarb therapy in a critical care setting because we frequently encounter patients with metabolic acidosis in addition to the multi-organ failure that they have. So as presented earlier, I think the main thing we need to know that is absolutely crucial to first identify the cause through the stepwise approach, which could be very helpful in identifying, and of course to treat the underlying cause, as in cases of DKA or lactic acidosis due to either sepsis or cardiac arrest, etc. So treating the cause is utmost important. Now, next comes the question on whether giving IV sodium bicarb is useful or helpful. So I'll take us through a brief overview of sodium bicarb, what sodium bicarb is, and when is it used, some recommendations that we've found, what are the evidence that could possibly support it, just as a refresher. And then also after this, I will invite Dr. Wong to also share his comments and input on the best practice of IV sodium bicarb used in a critical care setting. Okay, so now first question to address is when is sodium bicarb usually used? So if you look up to date or various resources, usually it will be for severe metabolic acidosis, especially with a hemodynamic instability, because the consequences of severe metabolic acidosis could cause a reduced left ventricular contractility, cardiac arrhythmias, arterial vasodilation, venous constriction, and also impaired responsiveness to catecholamine vasopressors. So based on these reasons, we would want to correct the acidemia or the acidosis in the patient to help improve their prognosis. So examples of use could be in resuscitation during a cardiac arrest. However, evidence against this is conflicted, and then in cases of shock. Now, recommendations generally say that it's mostly given when arterial pH is less than 7.1 to the range of 6.9 or 7.2 with a goal to maintain arterial pH more than 7.1. And in patients with AKI, the goal is to raise the pH to be above 7.3. Now, overall, I won't be showing you all the evidence, but looking through various sources, the evidence is lacking to support routine use really, but some argue there's also lack of evidence to suggest that it's harmful. So this topic actually remains controversial in my reading. Now we just look at the adverse effect and potential harms of sodium bicarb first to understand why there's some hesitation to use it or what are the possible side effects. So hypokalemia is one adverse effect, hypocalcemia, hypercapnia through sodium bicarb combining with acid and then becoming carbonic acid, which is then change to CO2 in the blood. Hypernatremia because of the sodium load, volume overload related to hypernatremia through the amount that you are giving. Rebound metabolic alkalosis, especially in cases of lactic acidosis, when it's corrected and then the extra bicarb will cause a metabolic alkalosis, and also it promotes the acceleration of lactic generation. Okay, as we saw in the two scenarios, the earlier scenario 4 and 5, it seemed like sodium bicarb actually didn't help much for those two patients in the case of the lactic acidosis. Now, so when would sodium bicarb be potentially useful? So some suggest that it is best for bicarbonate losing situations. So for example, in patients with diarrhea, polyuria or RTA, where they have a hyperchloremic metabolic acidosis. And so this will be represented by a normal anion gap metabolic acidosis through the interpretation of a blood gas and the RP. Right, so there's a bicarb deficiency, compensatory raise in the chloride, and so replenishing bicarb would seem to be reasonable in these situations. Also, when compensatory defenses have failed, hemoglobin is a major buffer also, and so if there's anemia or there's renal impairment, then sodium bicarb could potentially be helpful. In cases of hyperkalemia, some practice giving bicarb as part of the regime to bring down the potassium. And cardiac arrest wise, I think the AHA guidelines do not recommend using sodium bicarb except in extreme cases of prolonged CPR. But there are increasing arguments. If you go online to find, some people argue that actually there's no harm giving it early and try to see if the patient could be salvaged. Now, CKD with uremic acidosis and hyperkalemia, oral bicarb is shown to be has a role to retard or to delay initiation of RRT, but that won't be the focus of our discussion today. Now, how about high anion gap metabolic acidosis? For lactic acidosis and ketoacidosis in DKA, bicarb is actually not helpful in these situations. Okay, so what is in IV sodium bicarb? Do we know what's its content? We know it's 8.4%. And then we hear about 4.2% and isotonic bicarb, which we like to use sometimes in our ward. So just to bring us through, how much sodium bicarb is in 1 ampule of pure sodium bicarb of 8.4%. Now, if we look at the atomic weight of sodium bicarb, 1 mole is equivalent to 84 grams. Now, 1 ampule of 10 cc, 8.4%, meaning 8.4 grams in 100 cc. So 1 ampule is only 10 cc, will give you 0.84 grams of sodium bicarb. And in that small vial of 10 cc, you have 10 millimoles of sodium bicarb. So actually, it comes down to 1 cc equivalent to 1 millimoles of sodium bicarb. Right, so this is just to make it easier for you to remember. Right, so they've diluted in such a way that 1 cc equals to 1 millimole of sodium bicarb. Other countries, they have other preparations, but generally this is what we have here. Now, in terms of how much sodium is there, just to give us an idea compared to normal saline. So normal saline, we know is 154 millimoles per liter of sodium. In sodium bicarb, it's actually 1000 millimoles per liter concentration. So it's actually a concentrated solution, and serum osmolarity is 2000 millimoles per liter. So normal saline is the isotonic 308 millimoles per liter. And sodium bicarb, if you give pure, you're actually giving up to 2000 millimoles per liter. So giving pure sodium bicarb through a peripheral ring isn't a good idea because it's going to be super hypertonic. Now, what happens if you try to halve it? Some practice giving 4.2%, as we will see in a while in one of the trials as well. So that gives you a less hypertonic solution, but still hypertonic because it's still 1000 milliosmoles. And if you dilute it even by half after that, it's still 500 milliosmoles, it's still a hypertonic solution. Now, the isotonic bicarb that we commonly use roughly would be a 74 cc of 8.4% in 425 cc of water. So that would make up about 1.26% of a sodium bicarb, which is about 300 milliosmoles and sort of isotonic. So actually it's a very diluted version of sodium bicarb. Right. Now, how much to give? There are various ways to calculate the deficit. I've sort of found out three suggested methods. First method is taking the volume of distribution times your weight, and then times 15, which is sort of your target bicarb minus your current bicarb. Right. So volume distribution times weight roughly gives you actually the total body water. So if you check with it's roughly same with the second formula, except that the second formula uses 24, which is the ideal bicarb. But in correction, you probably will not want to correct until 24 right away. Reaching to a bicarb level of 15 might be reasonable. Now, there's a pediatric practice that's used by our pediatric counterparts. They use weight times the base excess divided by 3. So this gives the bicarbonate deficit, which they then correct through a half correction and then subsequent corrections. So should you give sodium bicarb as a bolus or in a drip? In emergency situations, you may give up to 1 to 2 milliequivalents per kg, sorry, not per liter, per kg bolus. So for example, if a 50 kg person, you may give 50 milliequivalents or 100 milliequivalents of sodium bicarb. Now, how you want to give it, whether you want to give pure or you want to dilute it in 4.2, I think our current pharmacy formulary suggests that you should give as a 4.2 infusion. All right. Other suggested measures, you could give a half correction first of the deficit and then a slow infusion to complete it. Now, there is one recent, well, not so recent trial in 2018 called the BICAR ICU trial, where they randomized 389 critically ill patients with metabolic acidosis with a mean bicarb level of 13, elevated lactate. Right? They didn't differentiate what kind of acidosis were these patients, but these patients were assigned to either infusions of sodium bicarbonate using 4.2% or to no sodium bicarbonate, and they wanted to target a pH of greater than 7.3. So inclusion criteria was that the pH must be less than 7.2, the PCO2 must be less than 45, meaning there's no respiratory acidosis to confound it, and bicarb level less than 20, and a SOFA score more than 4, and arterial lactate more than 2. Now, patients who were already started on bicarb therapy on the outset were excluded from this study. So the bicarb solution that was given was a 4.2 bicarb infusion. Seems like they gave him boluses 125 to 250 in 30 minutes with a target to bring up the pH to more than 7.3 and a maximum of 1 liter per 24 hours. All right. So the outcome of the study, the primary outcome was to study whether there was a 15% reduction in mortality. So this is briefly the outcome of the trial. It showed that actually bicarb therapy had no statistically significant effect on mortality at 28 days or organ failure at 7 days. So there was no difference overall. But among a subgroup of patients with severe acute kidney injury, AKIN 3 and above, right? We found that bicarb therapy actually reduced 28-day mortality, and then also the need for dialysis by reductions in hyperkalemia, acidemia, and oliguria, which are the common indications for renal replacement therapy. Now, just looking at it on the flip side would be those who were treated with bicarb, they did experience some complications like hyponatremia, hypokalemia, hypocalcemia, but that didn't cause a measurable effect on mortality in this 389 patient study. So what does this tell us as a bottom line? That bicarb therapy could potentially be useful. This trial does not really conclusively say that it's better to give or not to give. But those who are using bicarb, perhaps it comes as a reassurance that it is not causing more harm. But those who are not using bicarb, who do not routinely want to use bicarb, there is no evidence to suggest that you are doing something wrong. Yeah. So more studies are really needed to establish this. So this is what from my reading and from looking up with regards to bicarb therapy in a critical care setting. Okay, so is IV sodium bicarb good or not? Maybe I'll invite Dr. Fong to share his comments and his thoughts on what the practice ICU.
Hi everyone. Hi. First of all, say thanks for inviting me to your CME. And I'm very impressed that you managed to finish up all the slides within less than an hour. That's a very heavy load of information for everybody. But very, very good slides. Sorry I couldn't give my feedback earlier, but I think there were a bit of slight mistakes in the formula there, but nothing will go through it. But in terms of sodium bicarb, this is a bicarb ICU trial, which actually I think is quite a good trial. And I think in our resource limited setting like us, the fact that we can reduce the use of dialysis, or some of them delay or prevent the use of dialysis in some patients, I think it's a very big benefit for us. So, like you have already shown, I don't think I have much to add. Already shown most of it. Sodium bicarb is useful for patients with normal anion gap metabolic acidosis. In terms of these kind of NECMAs, majority of the cases that we see are those patients who have renal failure. Of course, recently with the COVID outbreak, we have seen a lot of patients with poor oral intake, vomiting, diarrhea, coming in with severe, hyperchloremic acidosis, and they're all due to bicarb losses. And so those patients actually they did recover, they did do quite well with bicarb infusion, either oral like short solution or give isotonic bicarb. So the choice of sodium bicarb, the concentration actually really depends on how much volume you're willing to give the patient, or how much volume that the patient can take. So like in this study, in the bicarb ICU study, they used 4.2%. I would think 4.2% is a very good compromise. 8.4% is a bit too hypertonic, and you can only give in small amounts via a central line. 4.2% you can give in small boluses like 100 mils, 200 mils, and then we can repeat the ABG and decide whether he needs a second dose. Alternatively, if you were to give it more gentler and patient has time to to slowly correct, then isotonic bicarb will be the most gentle. So a prolonged infusion of isotonic bicarb, but it causes a very slow change in the bicarb. So whether good or not, I think it's useful for certain patients, especially so for those with renal failure, as shown in the bicarb ICU trial. But in terms of lactic acidosis, ketoacidosis, you're right to say that it doesn't help, except for conditions when the pH is less than 7.15. So I think the septic surviving sepsis campaign guidelines also did have a recommendation. We only use bicarb for lactic acidosis only when the pH is less than 7.15. So like you mentioned, less than 7.1, with the range between 7 to 7.2 around there. So anything below 7.1, I would think, yeah, you want to buy time while you're correcting the hypoperfusion, yes, you give some bicarb. but we need to correct the underlying hypoperfusion for the patient to survive. In fact, lactate is not really our enemy, and restarting acidosis from the lactate is actually just an indicator that there is a hypoperfusion going on. So lactate being there is not actually bad for the patient. Lactate is actually of course a byproduct of anaerobic metabolism, but it's also a source of energy for the patient in an anaerobic state. So actually lactate itself is not the enemy, but the resulting acidosis can cause a lot of urinations. So to buy time while we're correcting the hypoperfusion, then you give a bit of bicarb, but you need to keep monitoring because, like you mentioned, it can cause a hypokalemia, fluid overload, and when you give it to a lactic acidotic patient, it actually increases the intracellular lactic acid. So while the pH in the serum has improved, the pH in the cells has actually worsened when you give bicarb in lactic acidosis. Okay, yes, sir.
Thank you very much, Dr. Fong, for the comments.
Yeah. Just one more thing, on slide 18, I think there's one formula there, the simplified one, just so that we don't, because I tried to use formula, then I was a bit confused. I think
this one is it?
Slide 18, 18 plus. One more slide back. This one. The respiratory alkalosis. No, the next one. This one. So the respiratory alkalosis it should be 40 minus PCO2 lah. The respiratory alkalosis acute 24 minus, I think it should be 40 minus PCO2, right? And then the chronic, it should be 40 minus I mean bigger number minus smaller number lah.
Okay.
Otherwise it becomes negative, and then the calculation is a bit off lah. Yeah. I think this is a good one. Winter's formula is also okay, but this is good enough lah. Yeah.
Okay.
So just a few more tips from me. Lactate, right? Usually lactate, whenever you have lactic acid, one lactate usually translates to a drop in bicarb by 1.
Oh.
So let's say in the first, I think case one was the case where the lactate was 18. Lactate was 18, and then you count the NR gaps at 18. Or the bicarb has gone down by 18. If you were to look at the base excess, you most likely see the base excess as negative 18 lah. So usually 1 bicarb to 1 lactate, usually lah. So when you see a case like the last one, where the lactate is only 2, right? And then the bicarb was very, very low. So that one you know that, okay, the lactic acidosis itself does not explain the severe drop in bicarb, like this one. So bicarb less than 3, lactate is 2. So there's something else that's causing the bicarb to be that low lah. It cannot be lactic acidosis alone. So like in this case, if you were to count that there's a high anion gap metabolic acidosis, then you have to actively look for ketoacidosis, usually lah, right? That's the other common one lah. If it's not uremia, then most likely it's ketoacidosis, that kind of thing. Yeah.
Okay, thank you very much, Dr. Fong, for the. Yeah, just to add on a little bit, I think ketoacidosis is something we always have to consider, especially if in a HAPMA. Although sometimes the DXT might be normal. Actually, in this case, you see that the DXT was 7. So normally we would sometimes definitely say, oh, this cannot be anymore. But we know that there's this entity of euglycemic ketoacidosis. And alcoholic ketoacidosis is not very common, but a possible situation. So always think ketone is always good to rule out. I think a few times I've encountered patients with normal DXT, unexplained acidosis, and lo and behold, when you only do a ketone.
Sometimes it can be starvation ketosis as well, right?
Yeah.
And they didn't eat, yeah. One thing you didn't mention, I think, inside, I just want to add on is hypoalbuminemia. Actually can affect your anion gap calculation.
Oh.
So if you have a patient with hypoalbuminemia, because albumin is also a buffer, so whenever there's low albumin, then you have to correct it. There's a calculation for it.
Okay.
I think for every drop of albumin of 10, I think you have to, you're underestimating your anion gap by 2.5, something like that. So
Okay.
just to be on the lookout for very low albumin, and then you say, like, why is this patient having normal anion gap when it's you would expect it to be high, but then why is it normal anion gap? And then you look at the albumin level, it could be very low.
Okay. Okay. We'll keep that in mind.
It's an extra thing.
Okay. We open the floor briefly to anyone who has any questions, either to the presenters or to Dr. Fong.
Dr. Fong, Ng here. Just want to
Hi.
clarify again, because I think previously there has been, I'm not too sure whether this is a dogma or whether this is, we hear it from seniors. In general, right, critically ill patients with very severe metabolic acidosis, is it absolutely mandated that we need to intubate them to take over the ventilation?
No, it's not absolutely.
Because
I
my
think it
understanding
depends
was
on
that,
how,
because my understanding is that in such patients, right, the only thing that is keeping them from collapsing directly is that they are typically very tachypnic and they are compensating. So by intubating them in itself, especially when you paralyze them, right, that very brief period where you paralyze and they're not compensating by the tachypnea, you can actually just worsen the situation.
Yeah, actually you're very right. I just had one patient basically told on me yesterday, a very severe acidotic, metabolic acidosis patient came into our ICU, and then he was decided to be intubated. After intubation, somehow my medical officers that set a rate of 18, which started 400. Prior to that, the patient was breathing at a rate of 35. So from rate of 35, spontaneously breathing, and then suddenly after intubation, it was at the rate of 18, and the patient straight away went into severe mixed acidosis and systole. So you're very right. If you were to need to intubate a patient, sometimes what happens is they become unconscious, or there's some other hypoxemia involved, which that forces you to intubate the patient. If we really do have to, then we have to try to match the minute ventilation that he was breathing prior to intubation.
In such a situation, will giving boluses of bicarb help to alleviate the situation?
The problem with giving bicarb to a patient who is having respiratory.
The CO2, the CO2 washout.
Yeah, correct.
The additional CO2 burden.
Yeah. So if he had some sort of what do you call it? Ability to wash out more CO2. I mean, if he could actually had some more space to hyperventilate, then okay he would be able to wash out the CO2. But if he could not, then the CO2 will start climbing, and then you have some other issues.
Then okay. Yeah, thanks a lot.
Yeah.
Okay. Thank you again for the question. And any other questions from the floor? Okay, going once, going twice. Right. If not, then.
Sorry. Probably there's another question as well. Just want to clarify. Well, I noticed some places, right, they do not practice. They practice isotonic bicarb, but they use a slightly reduced bicarbonate content. I think they do. I think, if I'm not mistaken, I think in HKL there are two forms of dilutions for isotonic bicarb. If I'm not mistaken, one where they instead of running 75 cc's of sodium bicarb in 425 cc's of D5 or water for injection, they do 37.5, but I think they use a QSD1 drip instead as a replacement. Is there any specific preference for either one of them, or is it more because it's more of the target bicarb that you want to achieve?
Yeah, I would think that's the amount of bicarb you put in. It really depends on how fast you want to correct and how severe the metabolic acidosis is. So if you were to use that is more like a half isotonic. If you use 37.5 plus a QSD1, the solution will be a little bit hypotonic I guess a good compromise maybe is that if you use half of the bicarb, then you would give half saline. To maintain the osmolarity. And then there are some conditions where you want to use either D5 or water for injection. Hello?
Yep.
Yeah, sorry. Yeah, D5 water for injection actually both are interchangeable. You can still use 77 mils in D5 or 77 mils in water for injection.
Okay. Okay.
Yeah.
Thanks
but
a
if
lot.
you're adding for the half saline, then you have to cut it down, otherwise it'll be hypertonic.
Okay. Got it.
There's a calculator, I think I used before. There's an online calculator to calculate the osmolarity. Depend on how much sodium bicarb and what kind of solution we use.
Okay.
Probably there's something online there.
Okay, sure. We'll look on it. Thanks a lot.
Okay.
Right. If there are no more questions from the floor, we will end our presentation here today. So very big thank you to Dr. Fong for taking time to share your comments and also the guidance and tips on acid-base balance in a critical care setting. Thank you very much, Dr. Fong. And thank you to Dr. Stephen and Dr. Ho as well for the presentation.
Okay, thank you everyone.